We'll be discussing burns and burn management. By the end of this session, you'll be able to identify the 4 degrees of burns, list the 4 initial steps in the management of burns after completing your primary or initial survey, list 3 findings suggestive of an airway burn, and list 3 hazards of smoke inhalation in a confined space. Burns are damage to biologic tissues from energy, so they're a form of trauma, transfer of energy from one source into tissue. And the 4 major types are thermal, chemical, electrical, and radiation. Of those, thermal are the most common, and they can result from flames or scalds, which would be hot water exposure or contact with hot substances such as hot metal or vapors. Chemical burns are caused by chemical reactions with the skin, and there may or may not be a thermal component to that. Oftentimes it's simply just a chemical reaction. Electrical injuries, and we'll include lightning injuries with this, occur in 2 ways. There can be direct contact with an electrical current, so current flows through the individual from a voltage source to a ground, or there can be arcing of electricity between 2 contact points near the skin, and there tends to be a bit more of a thermal type injury, although there can be an electrical current injury component to that as well. Radiation, both ionizing and non-ionizing radiation, can also cause burns, and those burns typically result from a high level of radiation exposure to a specific anatomical area. Otherwise, you can just see the mutagenic effects of the ionizing radiation, that is, they turn cells into cancer-type cells. But we're talking about actual physical burns or radiation burns in this case, so it's high level of radiation over a specific area. So if you can remember this, you can manage burns. First and foremost, protect yourself. Stop the burning process. If somebody's on fire, put them out. If something is burning them, try to remove that. Then it's back to your standard initial assessment. X, A, B, C, D, E, F. Manage life-threatening trauma. Burns typically are not immediately life-threatening unless they involve the airway. It's the other trauma that happens that's going to kill the individual. So you need to manage life-threatening trauma first and arrange evacuation. Then anticipate and manage their fluid loss. That's where people get into the most trouble with burns, is through fluid loss. So you need to manage that with IV fluids. And finally, manage the burns themselves. So pain control, dressing the burns, cleaning the burns so that you prevent infection or decrease the risks, and that promotes the best cosmetic outcomes. So what happens when you're exposed to burning process? And we'll talk really about thermal burns, although this also would apply to chemical burns, electrical burns, or radiation burns. And so the degree of the destruction depends on how hot it is and the duration of the exposure. And that's really about it in terms of how much energy is imparted. Now what that energy does, how much damage it does, will depend on the water content of the skin, the thickness of the skin. Darker pigmented skin handles that high thermal energy better. Presence or absence of anything that insulates it, so skin oils or hair will absorb some of that energy and protect the skin. And then peripheral circulation of the skin, so areas that have a lot of good blood flow that pulls the heat out of the skin and moves it centrally, but it takes it away from the skin and decreases the damage in that area. So obviously there's a local burn, and that's what we see. But what really affects your patient in the short term, days, hours to days, and their long-term outcome is the systemic response, how the body reacts to the burn injury. So the big immediate effect is hypovolemic shock, shock from loss of fluids. So you lose a lot of fluid during the initial burning process. You're burning tissue, you're evaporating fluids. Then you form a covering over the burn called an eschar. Your body does that as part of the healing process, but fluid will move across that and evaporate. You'll lose fluid that way. There's also continuous leakage from burned vessels, so you're continuing to lose blood volume. You also decrease venous return, so because you've had this fluid loss, and so you decrease your cardiac output. And so your body increases vascular resistance, so it's harder for blood to get to the burn itself, although in the area of the burn, those blood vessels really are all dilated up, and so what fluid gets there then leaks out. You get hemolysis, which is breakdown of red blood cells, and that can damage your kidneys. It also decreases your ability to carry oxygen. And you get rhabdomyolysis, or breakdown of muscles. And that muscle breakdown is particularly damaging to your kidneys, and it releases a lot of other toxins into the bloodstream that challenges your already challenged burn patient's status. So to figure out what we need to do about a given burn injury, we need to classify that burn injury. And we need to classify it accurately, which means we need to do a good assessment. Burns change over time, and the initial damage may not be clear until hours or days after the injury. So you need to follow this over time and change your assessment. I had a patient who was seen on a Saturday. She had a scald burn from hot water to her abdomen. She was told that she had first and second degree burns. I saw her back in the emergency department on a Tuesday, and by then she had necrotic, insensate areas in the center of the burn, areas where the skin was breaking down and where she couldn't feel anything at all, and the surrounding redness was very painful, and she had blistering, and so she actually had progressed to third degree burns, which were much more significant. Burns are most commonly classified by their depth, and they're classified as first, second, and third degree burns in almost every scheme. First and second degree burns are partial thickness burns. That is, the skin is only partially burned through. The integumentary, the outermost layer of our body, is not completely burned through. And as long as there's not infection or the patient doesn't go into shock and have trouble getting blood flow to those injured areas, they usually heal without any surgery. Third degree burns are what are called full thickness burns. So the skin is burned all the way through, and the problem there is that the layer of the skin that regenerates and grows new skin is all the way at the bottom, and if you burn through that, there's really not an area, a part of the skin to grow new skin from, and so those patients usually require skin grafts to heal that area. So a first degree burn is the epidermis, the outermost layer of the dermis, or integumentary only. You get local pain, you get redness, you don't get blisters, and these typically heal on their own in 2 to 3 days without any scars. There's very minimal systemic response, there's no shock. This is sunburn. Very uncomfortable, but not typically life-threatening. Unfortunately, at sea, sunburn's a real problem, particularly at the more tropical latitudes, but really anywhere there's good clear sun exposure, you can end up with a sunburn. And the key is to prevent this. So if you're out in the sun, use a sunscreen of a sun protection factor, SPF of 30 to 50, wear appropriate clothes, and as much as possible, stay out of the direct sun, particularly from 10 a.m. to 3 p.m. when it's at its highest and most likely to cause a burn. Second degree burns are typically divided into superficial and deep partial thickness burns. They go through the epidermis, the outermost layer, and the dermis, but not all the way through the dermis, so the underlying tissue is burned as well. These are moist appearing burns, and they're partial thickness. They're not complete thickness burns. The sensation is intact, so they can feel light touch in the area of the burn, and it's very painful. And as you can see from this picture, the big thing that differentiates this from a first degree burn is the presence of blistering, because you've burned all the way down to the dermis, so fluid collects between the epidermis and the dermis. If there's no infection, these typically heal without scarring. You can also have deep partial thickness second degree burns, and that's the epidermis and the dermis all the way down to the base layer of the epidermis, but not all the way through. These are also very moist appearing, but can be dry and white if the blood vessels themselves are injured. The sensation is usually intact, but this is deep enough that the nerve endings start to be affected. So while touch and pain sensation is there, it may be diminished compared to a superficial partial thickness. Infection is a big risk, and these can be fairly extensive with blistering, and the blisters can be large and can rupture. So this was a firefighter, and the back of his turnout coat got pulled up in a fire, and he ended up with this burn. In a third degree burn, the burn goes through all the layers of the skin. So you burn completely through the skin to the underlying tissue, and you destroy the part of the skin that regenerates new skin. The color can be very variable. It can be white or waxy, red or brown, but there's destruction of the blood vessels and the other underlying structures. The skin is no longer elastic and it's dry. Now, because the nerve endings are burnt out, the third degree burn itself is painless, but the surrounding first and second degree burns still hurt. So don't think just because they're having pain that they don't have a third-degree burn. You have to assess the full burn and figure out if there's part of it that has no sensation at all. And because you've burnt all the way down through the base layers and through the regenerative layers, typically without a skin graft, these will not heal. They'll form a bad scar. So some classification systems actually include fourth-degree burns. And this is a full-thickness burn that doesn't just burn through the skin, but burns all the way down into the underlying subcutaneous tissue, or into muscle, or the muscle coverage, the fascia, or into the covering over the bone, the periosteum, or burns bone itself. And you can see from this picture, these are very extensive injuries with quite a bit of destruction. So aside from knowing how deep the burn is, you also need to know how much burn there is. And so we use something called the rule of nines, and this works well in adults. It's okay in kids. There's actually special charts for kids that are used, but for adults and children over 10, this will give you a pretty good estimation of the size of an injury. It starts with the assumption that a patient's hand is approximately 1% of their body surface area, so the palm and fingers. So any burn that you can cover with a palm and finger, each one of those is 1% body surface area. And if you look at that, you come up with these general rule of 9%. So the head is 9% of the body surface area. The chest is 9%. The abdomen is 9%. The entire back is 18%, or 2 times 9%. Each arm is 9%. The legs are 18% each, or 9% in the front, 9% in the back. And then genitalia are 1%. That brings you to 100%. And when you're estimating the extent of the burn, it's not a one-size-fits-all thing. It's not that if they have any burn at all on the arm, you get the full 9%. If you burn half the arm, it's 4.5%. If you burn the chest and half the back, that's 18% total. 9% for the chest, 9% for half the back. So when you're taking care of a burn patient, shipboard, you need to make a determination. How serious is this burn? So the American Burn Association, or the ABA, has a classification system. And for civilian EMS and hospitals, this helps guide them as to whether or not patients can go home, or if they need to be admitted to a hospital, or if they need to be transferred to a burn center. For you, you can use this, generally speaking, as guidance as to whether or not a patient has a significant burn that requires evacuation. Anything in the moderate or major categories requires evacuation. Minor, you speak to medical control, but you may be able to manage them shipboard. So for minor, it's adult with less than 10% body surface area of a second-degree burn. For young or old, so children or those over 55 to 60, 5% body surface area second-degree burn, or less than 2% full-thickness burn is considered minor. Moderate would be an adult with a 10 to 20% body surface area second-degree burn, or young or old individual with 5 to 10%, a 2 to 5% full-thickness burn. Any high-voltage injury, so not necessarily a burn from high voltage, but an injury caused by high voltage. Possible inhalation injuries, burns that go completely around an extremity or completely around the chest, what's called a circumferential burn. And this isn't first degree. We're talking the second degree partial thickness burns, because those can actually cause a lot of swelling and cut off blood flow. And anyone with other chronic health problems, so people who just aren't healthy, that's moderate. And then major, any adult with a greater than 20% body surface area second degree burn, young or old with greater than 10%, greater than 5% full thickness burns, any high voltage burn, so an actual burn from the electricity, a known inhalation injury, and we'll talk about how you would determine that shortly, significant burns to the face, joints, hands, or feet, and any associated trauma falls into the major category. So your first priority is to protect yourself. Burns happen because things are on fire, and when things are on fire, you can get hurt too. So as we do our initial assessment or our primary survey, we may be looking for other trauma, but we're also looking for signs of significant burn injury. And with the airway, there's some red flags that there have been airway burns. These are very concerning. Someone with an airway burn who gets swelling at the level of the voice box, the vocal cords, they can have their airway block, swell shut in minutes, and they'll die from that. And so you need to be conscious of the risk for that. So as you're doing your airway assessment, burns around the mouth, any soot in the mouth or nose, singed nasal hairs, a burnt tongue, tongue swelling, a hoarse voice, swelling in the back of the mouth, or when they breathe in, a high-pitched squeaking noise, really bad signs. And those are obviously progressive. Burns around the mouth are worrisome, but don't mean there's a burn. Inspiratory stridor means there's already swelling at the level of the vocal cords and they're swelling shut. Problems with breathing, circulation, and altered mental status are also concerning, but those airway findings are particularly concerning. If you don't have any primary assessment findings, then you go to your history and you think about what's the patient's chief complaint. Is it pain? Okay, they have a burn, they're painful. Is it trouble breathing? That's more concerning because you have to think about why they're having trouble breathing. Is it because of an airway burn or is it because of another inhalation injury? Try to figure out what the circumstances of the injuries were. If it's an enclosed space, that means very different things, and we'll talk more about that in terms of toxic exposures, in terms of the amount of heat that they could be exposed to. If there was an explosion, they could have traumatic injuries. Were there hazardous chemicals involved? So could there be a chemical injury, and was there other trauma? And then what was the source of the burning agent? Was it contact with flame? Was it hot metal? Liquids, which tend to cause more circumferential type injuries? Chemical, electrical, or radiation? You need to know these things to figure out the treatment of your patient. Does your patient have any significant chronic medical problems? Think about that American Burn Association classification. Somebody with a minor burn, an adult with less than 10% body surface area, second-degree burn, if there weren't other red flags, suddenly becomes a moderate burn if they have chronic medical problems. So you need to identify these. What medications does the patient take, including any illegal drugs or alcohol, which can affect both their judgment about the burn and their healing? Did the patient lose consciousness during the burn process? Then you have to worry about what they may have inhaled. And is their tetanus up to date? Shipboard, everyone's tetanus should be up to date, but you need to confirm that. Burns are very high risk for tetanus infection. On exam, you want to obtain a complete set of vital signs, and then you need to make a decision regarding evacuation, and that's anyone in the American Burn Association's moderate or major classification needs to be evacuated. It's more than you can really safely and appropriately take care of shipboard. So once you've stabilized your patient for whatever other trauma there is, then you need to think about what your goals of burn management are, and you want to prevent further tissue injury. You want to make sure that they have an open airway, give them oxygen, support their breathing as needed. You need to remember they're going to lose a lot of fluids, so you need to provide fluid resuscitation. If you think they need to be evacuated, make those arrangements. And if you're going to keep them on board, or even in your initial management of their wounds, use clean technique so that you decrease the chances of them getting an infection in this area where you've now destroyed the skin's protective barrier. And provide psychological and emotional support. For burn victims, the trauma of the burn can last for years or decades, not just the physical trauma, but the emotional trauma. And there are plenty of studies to show that burn patients often have trouble coping with their lives for years after the burns, even after the physical manifestations of the burns have healed. So to prevent further tissue damage, you need to stop the burning process. Make sure the scene is safe for the rescue crew. For minor first-degree burns, you can just cool the local area with cold water. And there's a fair amount of evidence that after a minute of cooling a burn, you really don't have that much more effect in heat dissipation, although it feels good to cool it. So continued cooling isn't a bad thing necessarily, as long as you don't overcool the patient and make their body temperature drop. But you're probably not getting rid of a lot more heat as long as there's not some adherent material or something stuck to the patient that's hot. For more severe burns, you want to get the patient out of their exposure as quickly and safely if possible. If the patient is on fire, put the patient on the floor or the ground and roll a blanket around the patient to smother the flames or douse them with large quantities of the cleanest water you have. But if it's dirty water, use it. You need to stop the burning process. Take off the clothing while you're cooling the burn, because the clothing will actually trap heat inside and continue to cause injury, so get that off. And then once the burn is cooled, cover the patient with a clean, preferably sterile, although you may not have a sterile sheet, but at least a clean sheet to try to minimize contamination. Remember, once you burn all the skin off, you've lost a large amount of thermal regulation. These patients are now really susceptible to their environmental temperature and can very easily become hypothermic because they can't control their temperature and they can't protect themselves from a cool environment. So you need to protect them from the environment, both heat and cold, after an extensive burn. Once you stop the burning, you've started to protect the patient, you need to think about supporting their circulatory status, and that's typically going to be fluid resuscitation, getting fluids into them based on how much fluid they're losing. So the severity of the injury, which tells you what their risk is for fluid loss, their vital signs, which tell you how the body is responding to the stress of that injury and the loss of fluid, and how long it's going to be until you can evacuate the patient. You're going to give them IV fluid therapy, and you're going to give them IV pain management to make them more comfortable. Now, there's risk involved with IV pain management. If they've lost a lot of fluid, they may be keeping their blood pressure up by the amount of adrenaline they're releasing because of pain. And so you give them just a little bit of morphine, which can lower the blood pressure, but not terribly so. But you make them comfortable, and they stop releasing all that adrenaline, all that epinephrine, and suddenly their blood pressure plummets. So analgesics are very important, but you need to make sure that you have the ability to give them fluid resuscitation as well at the same time if needed. So fluid resuscitation is nowadays considered to be the cornerstone, the key to managing burn patients. Now that wasn't always the case. Historically, fluids were often restricted, and this was true until the Coconut Grove fire. So the Coconut Grove fire was a nightclub fire. The people were trapped inside. There were many people who got burned, and one of them was a member of the Coast Guard who was there with a date, and when the fire first broke out, he got out of the building but couldn't find his date and thought she was trapped inside, so he went back in. It turned out she was already out, but he went back in and he suffered extensive burns. And so he, like many other victims, were taken to local hospitals, and because he had such extensive burns, it was felt he was likely to die, that there really wasn't any hope for him, and so he was actually given to a medical student to manage. And the medical student saw how much fluid seemed to be weeping from his body and thought, geez, maybe he just needs fluids. And he was a medical student, so he didn't know any better. Nobody told him this person was going to die, so he figured he would try to save him. And he did. He gave him large quantities of IV fluids, and the patient survived. And that really was revolutionary and changed the approach to giving IV fluids. Now, unfortunately, people still continued to underdose the fluids. And so the Parkland formula is a guide for the first 24 hours. Anyone with significant burns, this is the formula that makes sure you give enough fluids, because these patients are still often under-resuscitated, even in the present day. So it's 2 to 4 mLs of fluid, and that's IV fluid. Most burn centers recommend lactated ringers. If you don't have enough, normal saline is okay, but typically lactated ringers. So 2 to 4 mLs times the weight in kilograms times the percent of body surface area, total body surface area that's burned, and that's second and third degree burns. And that's the amount of fluid that you need to give in the first 24 hours. So if you have a 100 kilogram patient, a 220 pound patient, and they have 30% second and third degree burns, in the first 24 hours, you will give 2 to 4 mLs times 100 kilos, so 200 to 400 times 30, which is 6,000 to 12,000 milliliters, or 6 to 12 liters of fluids in the first 24 hours. It's a lot of fluid, but that's what they need. You give the first half of that over 8 hours, and then you give the second half of that over the remaining 16 hours. At the end of the first 24 hours, you look and you see how the patient responded to the resuscitation, and you look at their clinical condition. If their circulation is good, they've got plenty of fluid in their vascular space, then the kidneys are seeing plenty of circulation and they're going to make good urine, 1 to 2 mLs per kilogram per hour. Their mental status should return to normal. The skin should become warm. They're no longer in shock. Their mean arterial pressure should be greater than 60 millimeters mercury, and their pulse should be in the 80 to 100 range at most. It should be back into a normal range. So suppose you have a patient who doesn't have a significant burn. Evacuation is full of risk, and when you evacuate someone, obviously they can't work anymore, and so there may be patients with burns you're not going to evacuate. And in fact, you'll take care of lots of people with minor burns. So talk to medical control about the burns that you're seeing. As long as they fall into the minor category of the ABA classification, you can manage the wounds. Just manage them shipboard. You can, if they have blisters that are flattened, that have ruptured, you can debride those. You can cut that tissue off. Now, it's a little controversial whether or not you do that. There's not great evidence either way, but the idea is that if a blister has ruptured, that's a site for infection now, because there's a connection from the bottom of that blister to the outside world, and bacteria can get in there and cause an infection. If the blisters are intact, don't rupture them. They're sterile inside. Protect them. If they're on the feet or they're someone where they're just somewhere where they're going to get broken, they're on the hands of somebody who needs to use their hands to work, then talk to medical control. You could consider rupturing them and then cutting the excess dead tissue off. But if they're somewhere where they can be protected, don't rupture them. Put on topical antibiotics. And while there are fancy burn cream antibiotics, silver sulfadiazine being the big one, or Silvadene, the burn cream, any antibiotic is fine, and we use just topical Neosporin type antibiotics all the time. Dress the wounds and keep them sterile. Make sure you do routine dressing changes, and medical control will tell you how often to do that. Usually it's once a day or when the dressings soak through. You can consider this stuff called water gel, which helps to keep the wounds moist. Make sure you've got good pain control and monitor them for infection. And that's not something that happens in the first 24 or 48 hours usually. That's something that shows up 3, 4, 5, 7 days out, where they start to get an infection on top of the burn injury. Now, you also have to worry about inhalation injuries, particularly for people who are trapped in an enclosed space with a fire, because two things can happen. If it's a smoldering fire, there can be a big release of these toxic gases, carbon monoxide, cyanide, any petroleum-based or wool-based or silk-based product. So most furniture, plastic coverings, when that burns, it releases cyanide, and you can get severe cyanide toxicity from that. Also, you can get carbon monoxide toxicity, particularly when things are smoldering and there's incomplete combustion. So it's not turning into carbon dioxide, it's only burning to carbon monoxide. In high temperature enclosed spaces, you can end up with airway burns, not from flames themselves, but because the air gets so hot that when it gets breathed into the lungs, it burns the lungs, burns the airways. So those are your three big areas of concern, injuries or toxicities that can happen with fires in enclosed spaces, particularly, or any time there's an inhalation injury. You also need to be aware of the potential for chemical burns. This is obviously a patient's back. This is a burn from diesel. This is a patient who was involved in a motor vehicle crash. He was put onto a backboard with all his clothes still on, soaked in diesel because he was a truck driver. He was taken to a hospital where they didn't take him off the backboard. They didn't cut his clothes off. And after an hour or so, he was transferred to a trauma center. So by that point, he'd been laying in his diesel-soaked clothes for close to 4 hours on the backboard. And when he was taken off the backboard, he had these chemical burns on his back. And that can happen if you don't get rid of the offending chemicals as quickly as possible. So for a chemical burn, scene safety is key. Although remember, most people in toxicologic or hazardous materials events die from traumatic injuries, not from the toxic materials. So just keep that in mind, that it's the traumatic parts of the scene that are sort of more a risk for you than the chemicals necessarily. Consider using protective gear if there's an extensive exposure risk for these chemicals. As soon as you can, remove all the clothing, including shoes, which can trap the chemicals and keep them close to the skin. If it's a powdered chemical, brush it off. And the solution to pollution is dilution. So irrigate the affected areas with as much water as you can. Wash and wash and wash, and then wash more and wash more and wash more. As much water as you can put on. Sometimes people ask, well, what about water-reactive substances like sodium metal? If somebody has sodium metal on them, that's going to react with the air as well. And so if they're not already spitting smoke and fire, chances are that adding some water on won't affect that. But even then, large volumes of water will wash away those water-reactive materials and keep them from injuring the patient. So wash them with lots and lots of water. Don't try to neutralize acids or bases by using bases or acids on them. Use water. So again, the quick and dirty of burn management, start by protecting yourself. There's a reason the person got burned. Don't get burnt yourself. Stop the burning process. Put them out. Manage exsanguinating hemorrhage, airway breathing, circulation, disability. Expose them. Get all contaminated, smoldering, or burnt clothing off of them. Find clues as to what the exposure was. Then manage life-threatening trauma. Except for airway burns and inhalation injuries, burn injuries do not kill people immediately. They kill people over the short to long term. Your very short term, your immediate life threats are the traumatic life threats, and you need to manage those first. If the patient has a moderate to severe burn injury, arrange for evacuation, and then anticipate and manage their fluid loss. Use the Parkland formula to guide your resuscitation for the first 24 hours, or even the first 8 hours if you're going to get them away before then. And then after that, use the patient's clinical condition. And then manage the burns themselves with pain control and infection prevention. And what you're doing is trying to promote the best cosmetic outcome. Please complete any associated knowledge reviews. Thank you for your attention. And if you have any questions, contact your instructor or professor.